Let's start. Today's topic is the acute gingival infection. So normally gingivitis is the inflammation to the gingiva. So we are going to discuss the various acute gingival infections, in which first we are going to discuss about the necrotizing ulcerative gingivitis. So, what is necrotizing ulcerative gingivitis? Necrotizing ulcerative gingivitis is also called as French mouth, Vincent infection, acute ulcerative membranous gingivitis, spirochetal gingivitis, and acute ulcerative gingivitis. So, what is acute gingivitis? It is the painful inflammatory condition which affects the marginal gingiva as well as papillary gingiva, and it is less affect to the attached gingiva. So basically the acute gingival infection is divided into the two types. First one is a acute and second one is a subacute. So acute necrotizing ulcerative gingivitis is affects not only to the single tooth as well as to the whole group of teeth, that is it can be spread to the whole mouth. So there are different signs and symptoms of the acute necrotizing ulcerative gingivitis. So what is the first sign of the gingivitis? Mainly it is the crater-like depressions are present in the interdental papilla. So this it is the onset of this disease is the sudden onset. So it appears sudden onset crater-like depressions at the crest of the interdental papilla. So what happened? Sometimes the lesion get denuded. So there is a pseudomembrane present on the surface of the gingiva. So when the denudation of this pseudomembrane occurs, then it results into the gingival margin, which is red, shiny, and hemorrhagic. So the main characteristics of this disease is the presence of the surface pseudomembrane. Second signs of this disease is the gingival hemorrhage, pitted oris. It is also called as halitosis. Next one is an increased salivation, and it is also occurs in a disease-free mouth as well as in associated with the chronic gingivitis or periodontal pockets. Other symptoms, oral symptoms are the gingiva is extremely sensitive to touch, constant radiating gnawing pain is present. Taste is the metallic, unpleasant taste occurs, and excessive amount of the pasty saliva occurs. So there are extraoral signs and symptoms. Firstly, patient shows the local lymphadenopathy as well as slight elevation in temperature. Other signs and symptoms are insomnia, fatigue, anorexia, gastrointestinal disorders, as well as headache, and in some patients, mental depressions is also there. So, what is the main etiology of this disease? So, acute necrotizing ulcerative gingivitis is caused by bacterial infections. So main bacteria is the spirochetes and fusiform bacilli causes the acute necrotizing ulcerative gingivitis. So there are different local factors as well as systemic factors which results into the acute necrotizing ulcerative gingivitis. So the local factors of this disease is the pre-existing chronic gingivitis and periodontal pockets, then predominantly associated with the bacteria like spirochetes, bacteroids, fusiform bacteria in the plaque, smoking, and plaque related areas, and the areas which of the gingiva is traumatized. So the systemic factors of these diseases are the nutritional deficiency, debilitating diseases, and psychosomatic factors. Example is the stress. So how will you diagnose this disease? So this disease is diagnosed by the clinical findings, and the epidemiology and prevalence of this disease is it is an epidemic pattern. It occurs at all ages and it is not associated with the children's. It is a non-communicable disease. So, clinical course. So, acute necrotizing ulcerative gingivitis has the clinical course, which is first given by Pinberg et al. In 1966. He described this disease into the four stages. So, first stage of the necrotizing ulcerative gingivitis is the firstly The erosion of the disease, that is the erosion only occurs at the tip of the interdental papilla. So firstly, the disease occurs at the tip of the interdental papilla. Second stage of this disease is the lesion extend to the marginal gingiva and further erosion of the interdental papilla. So next third stage is the it affect then attached gingiva, and fourth one is the exposure of the bone. So basically Kinborg et al. Divided into the four stages. First stage one is the erosion of the tip of the interdental papilla. Second one is the after interdental papilla it extends to the marginal gingiva and some of the interdental papilla. Third one is extends to the attached gingiva, and fourth one is the exposure of the bone. So later in 1995, Cohen et al. Described these stages into the in details. He divided into the stages of the necrotizing ulcerative disease, gingivitis disease. So the first stage is the necrosis of the interdental papilla, tip of the interdental papilla. Second stage of the disease is the necrosis of the entire papilla. Third stage is the necrosis of the disease extends to the gingival margin. Fourth stage is the necrosis extend to the attached gingiva. Then fifth stage is the necrosis extend to the buccal mucosa. Sixth stage is the necrosis exposing to the alveolar bone, and last seventh stage is the necrosis perforated to the skin of the cheek. So according to the Horning and Cohen et al., first stage is the only acute necrotizing gingivitis. Second stage is the acute necrotizing gingivitis either or acute necrotizing ulcerative periodontitis, because in some patient attachment loss is occurs, then it results into the acute necrotizing periodontitis. Third and fourth stage, which is given by Cohen, is strictly necrotizing ulcerative periodontitis. Why? Because it affects the bone. Fifth and sixth stage of the stage is the necrotizing stomatitis, and seventh stage is the noma. So there is a specific treatment for the acute necrotizing ulcerative gingivitis. It is this treatment is divided into the three visits. That is first visit, second visit, and third visit. So what treatment should follow in first visit? First, complete history of the complaint of the patient. Then extraoral and intraoral examination. Normally, what you have to do in first visit, firstly, you have to record the chief complaint of the patient, then complete history of the patient, then you have to examine the extraoral as well as intraoral examination. Then after this, in first visit of the treatment, with the help of cotton rolls, you have to isolate that area and dry that area. After that isolation, you have to apply the topical anesthesia. Then with the help of cotton rolls or cotton fillet with normal saline either or 3% hydrogen peroxide, you have to clean that area. Then you have to remove the supragingival calculus, that is only supragingival scaling you have to perform. Or then if the patient is having the extraction, or if patient is advised any periodontal surgery, then you have to postpone the uh, surgery till 4 weeks. Why? Because there is a symptoms present till 4 weeks. After the 4 weeks, when the patient becomes symptoms free, then you have to perform the periodontal surgery. Then you have to advise the patient to use the mouth rinse. First, there are two types of mouth rinse you can use. First one is that you have to use two equal mixture of warm water and 3% of hydrogen peroxide every 2 hours, or you can give the 0.12% chlorhexidine mouth rinse daily, twice a day. Second, if in patient is moderate to severe case or is having also local lymphadenopathy, you have to give the antibiotic therapy. Why antibiotic therapy? Because this disease is caused by the bacterial infections. So basically, to treat the bacterial infection, you have to give the antibiotic therapy. So you have to give the penicillin 500 milligram orally every 6 hours, or you can give the erythromycin 500 gram orally in every 6 years. Second antibiotic should be the metronidazole, which is the 500 milligram twice a daily for 7 days. So you have to give the instructions to the patient. So the instructions are avoid tobacco, alcohol, avoid physical exercise, and do the brushing only to the supragingival level. Second visit. Second visit, you have to perform on complete scaling if the patient is allowed or if there is a no sensitivity. What happened in second visit? Because of the first visit, there is a shrinkage of the gingiva occurs, which results into the exposure of the previously covered calculus, which you have to remove the gently. And same instructions you have to give the patients, which are given in the first visit. That is to avoid the tobacco, alcohol, avoid physical excessive exercise. Then third visit. In third visit should be done after 2 days of the second visit. So in third visits you have to repeat the scaling and root planing. Then patient is instructed in plaque control procedures. Then in first visit, you have to advise the hydrogen peroxide rinse. So in third visit, you have to discontinue that mouth rinse. That is, you have to discontinue the hydrogen peroxide rinses and maintain the chlorhexidine rinses. That is 0.12% twice a day for 2 to 3 weeks. So after these 3 visits, there is a subsequent visit in which if those smooth surfaces are not completely scaled, so you have to perform the complete scaling and smoothing. Then plaque control by the patient is checked and corrected if it is necessary, and comprehensive treatment of the patients, that is chronic periodontal problem, should start. And if the patient is due to the enlargement, so additional treatment like gingivectomy you have to perform. What is gingivectomy? Gingivectomy is the removal of the gingival enlargement, to cut the gingival enlargement and shape the gingiva. So you have to perform the gingivectomy. So second disease we are going to discuss is about the primary herpetic gingivostomatitis. Second, so it is the basically viral infection. So it is caused by the virus virus. So what is primary herpetic gingivitis? It is an infection of the oral cavity which is caused by the herpes simplex virus 1. First we discuss about the acute necrotizing ulcerative gingivitis, which is the bacterial infections caused by the bacteria. And this disease, that is second disease, is the primary herpetic gingival stomatitis, which is the viral disease which is caused by the herpes simplex virus, that is HSV virus 1. So there are oral signs and symptoms. So basically the oral signs of the disease is the it is characterized by the various presence of the vesicles found on the gingiva as well as labial, buccal mucosa, soft palate, pharynx, sublingual mucosa. So there is a diffuse erythematous and shiny gingiva which is present, and degree of edema and gingival bleeding is also associated with disease. As in oral signs, you can see there is a painful small ulcers present on the soft palate, which is characterized by the vesicles. After the vesicle ruptures, this which is resulting to the ulcers with red light elevated margin, and in center there is a yellow gray white central portion depression is present. So other signs of the disease is the it is mainly associated with the children's. The course of the disease is limited to 7 to 10 days. Diffuse gingiva edema as well as erythema persist for several diseases, and scarring does not occur in the area of field ulceration. So, what are the oral symptoms? Symptoms are the generalized soreness of the oral cavity, which because of the soreness, patient is unable to, that is difficult to eat or drink. So what happened because of the vesicles? After the rupturing of the vesicles, there is a focal sites of pain. That is the rupturing of the vesicles resulting to the pain. So other than this, there are extraoral signs and symptoms. Extraoral signs and symptoms are the cervical adenitis, fever, that is 38 degree to 40 degrees Celsius, and general malaise are common extraoral signs and symptoms. So, history. What is the history of disease? So, in history, recent acute infection is a common feature of the history of the patient. So, how will you diagnose? The diagnosis is the usually established from the patient history and clinical findings. Communicability. So, this disease is the contagious. Is the most developed immunity to the HSV as the result of the infection during the childhood. So, this disease is a communicable contagious disease which occurs mostly in children. So, what should be the treatment of this disease? First, you have to apply the topical anesthesia. After that, aura-based compound with high potency topical steroids you have to give. Then, advise the chlorhexidine mouthwash. Basically, this disease is caused by the viral infection, so you have to give the antiviral therapy. So, antiviral agents are the acyclovir. You have to give the prescribed it, topical as well as systemic. Other than this, there is a supportive treatment Panadol that are non-antisteroid anti-inflammatory agents should be given to relieve the pain. Then in this disease, patient is unable to drink anything or eat anything because of the pain. So you have to give the copious fluid intake. Then other than this, systemic antibiotic therapy for the management of this toxic systemic complication in severe cases. Penicillin should be avoided because of it aggravates the herpetic lesions. So basically we are going to discuss about the difference between the acute necrotizing ulcerative gingivitis and primary herpetic gingival stomatitis. First difference between these two diseases is the first one is the etiology. Basically, necrotizing ulcerative gingivitis is caused by the bacteria and uh, primary herpetic gingival stomatitis is the caused by the viral infection, that is the HSV-1 viral infection. Second difference between these two diseases are the necrotizing ulcerative gingivitis is the necrotizing condition, while primary herpetic gingivitis stomatitis is having diffuse erythema and characterized by the vesicular eruption. Third difference is the necrotizing ulcerative gingivitis is the characterized by punch out gingival margin, that is pseudomembrane is present on the gingiva. When this pseudomembrane peels off, leaving the raw areas of the gingiva, marginal gingiva. So while in primary herpetic gingival stomatitis, there is a vesicles. After rupturing of the vesicles, it leaves the oval shape or spherical shape ulcers, and necrotizing ulcerative gingivitis is the not common in children, while primary herpetic gingival stomatitis is the common in most frequently associated with the children. So there is a no definite duration of the necrotizing ulcerative gingivitis, while for the primary herpetic gingival stomatitis, the duration course is the 7 to 10 days, and there is a no demonstrated immunity for the necrotizing ulcerative gingivitis, while acute episodes results in some degree of immunity for the primary herpetic gingivitis. Necrotizing ulcerative gingivitis is the contagious, not demonstrated, but primary herpetic gingival stomatitis is the contagious disease. So, moving towards the third disease is the pericoronitis. So basically what is pericoronitis? Pericoronitis is the inflammation of the gingiva which related to the crown or incomplete eruption of the tooth. So it is mostly associated with the mandibular third area. So what happened when there is a during the eruption, if the coronal flap is associated with the mandibular molars, then because of the pericoronal flap, there is a food accumulation occurs under this flap, which results into the inflammation to that area, so which results into the pericoronitis. So there are different clinical features of the pericoronitis. First one is a partially erupted or impacted mandibular third molar is the most commonly site of pericoronitis. Second is the space between the crown of the teeth and overlying gingival flap. It is also called as the operculum, is the ideal area of the accumulation of the food which results into the bacterial growth. This results into the red swollen suppurating lesions that is tender with radiating pains to the ear, throat, floor of the mouth. This patient is extremely comfortable because of the foul taste and inability to the close the jaws. In addition to the pain, swelling of the cheeks in the regions of the angle of the jaw and lymphadenopathy is a common finding of this disease. Trismus is the also occurs in some patients. Other complications are such as fever, leukocytosis, and malaise of the disease. So, complications of the pericoronitis is the involvement may be localized form of the pericoronal abscess, or it may be post spread to the posterior to the oropharyngeal area and medially to the base of the tongue, which results into the difficulty of the patient to the swallow. So basically, the treatment of the pericoronitis is the surgical treatment, non-surgical or surgical. In surgical treatment, in non-surgical treatment, first we have to perform the complete scaling and repairing with respect to that tooth, and along with the you can use the betadine irrigation to that area. And in surgical therapy, there is a two type. First one is a if the tooth is unerupted or half completely erupted, or still the pericoronal flap is present over the teeth, then you have to remove that operculum. That is why you have to remove that pericoronal flap. So the procedure is itself called as a operculectomy. Operculectomy is the removal of the pericoronal flap or operculum associated with the third molar. Or second treatment of this disease is the complete removal of the third molar. So basically, today we are discuss about the three diseases, that is three different types of acute gingival infection. First one is a acute necrotizing ulcerative gingivitis, and second one is a gingival stomatitis, that is primary herpetic gingival stomatitis. So basically, acute necrotizing ulcerative gingivitis is caused by the bacterial infection, and primary herpetic gingivitis is viral infection. And necrotizing ulcerative gingivitis is mainly characterized by the punch-out crater-like depressions in interdental papilla, and it is also characterized by the pseudomembrane on the gingiva. After this, after that, if the denudation of the pseudomembrane occurs, then the gingiva results into the red shiny. While in primary herpetic stomatitis is the viral infection, which is characterized by diffuse erythema as well as edema, and mainly associated with the vesicles, formations on the palate, buccal mucosa, cheek, tongue, or labial mucosa. So after this rupturing of the vesicles, it results into the oval or spherical culture with red elevated margins and white or gray depressions in the center. So necrotizing ulcerative gingivitis is mostly not common in children, and herpetic gingival stomatitis is specifically associated with the children, and the course of duration is 7 to 10 days. Basically, necrotizing ulcerative gingivitis is the bacterial disease. So in treatment, we have to give the antibiotic therapy, while primary herpetic gingival stomatitis is the viral infectious disease. So in treatment modality, you have to give the antiviral therapy. That is the basically a cyclovir drug you have to give the. So today it's done. We only discussed the three gingival infections.